Welcome back, everyone. We're going to start the medical emergencies with a brief overview of some of the common medical emergencies and some things to keep in mind when we are dealing with medical patients in the EMS setting. Some national EMS competencies that we need to be aware of is we should be able, as EMS providers, to apply fundamental knowledge, provide basic, and for higher levels, advanced emergency care and transportation based on the assessment findings for acutely ill patients. We also should be able to assess and manage basic and common medical complaints. We should have an understanding of the physiology, the assessment criteria, and management of medical complaints to include transport mode, whether lights or sirens or non emergent, and destination decisions. We should also have an awareness of patients with infectious diseases and understand the assessment and management of patients who may have those infectious diseases. For medical emergencies, we generally look at medical patients as patients who need assistance that are experiencing some form of medical condition related emergency. Sometimes these patients can have concomitant factors such as trauma, for example, a diabetic patient who was in an accident. Medical and trauma both don't exist in a vacuum and they're not mutually exclusive to one another. Trauma emergencies can involve medical conditions, and medical conditions can complicate traumatic injuries. Some of the common types of medical emergencies that we'll need to be able to recognize are emergencies like respiratory emergencies, where patients have trouble breathing or oxygen supply is inadequate. Cardiovascular emergencies caused by various conditions affecting the cardiovascular system. This includes both the heart and the vessels. You can think about heart attacks, also more commonly in medicine referred to as AMIs or acute myocardial infarctions. Systemic circulatory conditions like high blood pressure or low blood pressure. Neurologic emergencies are conditions that involve the brain. Gastrointestinal conditions, conditions like appendicitis, diverticulitis, or pancreatitis, and others. We need to be able to manage urologic emergencies, such as kidney stones. Endocrine emergencies. These are most of the time caused by complications of diabetes mellitus for us in EMS. Hematologic emergencies. For these types of emergencies, you can think things like sickle cell or various clotting disorders. Immunologic emergencies are emergencies where the patient's immune system is either compromised or may be highly activated due to a foreign substance, an infection of bacteria or virus. Toxicological emergencies, including things like poisoning and substance abuse. And medical emergencies that are relating around psychological or behavioral problems. And we also need to be aware of gynecologic emergencies involving the female reproductive organs. Some key notes when dealing with medical patients is the patient assessment is going to be more based on the history and more focused than it is with the trauma patient. In trauma patients, we're very physical and visual in the assessment, exposing the patient and taking a hands-on whole body approach, particularly for the unconscious patient. But for medical emergencies, we're going to focus on the nature of the illness, or NOI, the symptoms that the patient is presenting with, and the chief complaint. An important definition here, chief complaint is the patient's primary complaint. More often than not, patients are going to have more than one complaint, but you want to try and narrow down and start with a chief complaint. If you'll remember back from our assessment series, the chief complaint drives the direction where we start our medical assessment. We need to make sure that we establish an accurate medical history for these patients. Unlike trauma, medical emergencies are often covered by the skin or internal and hard to see and hard to visualize. So we're going to rely on those clues from the patient history to help glean insight into what's going on with the patient. We can use our dispatch information to guide our initial response, but remember that dispatch is a game of telephone, if you will. The dispatcher can only convey the information from the caller, and more likely than not, the caller is probably not a medical professional, and so information can get lost in translation there. Don't get locked into any preconceived ideas or notions about the patient's condition. We've talked before about implicit bias and patient bias and making assumptions about a patient's condition based on their socioeconomic status, or geographic location. Certainly, there are certain disease processes that impact certain demographics higher, but we don't want to tunnel into those and prevent ourselves from giving a full assessment and giving the opportunity for the patient to present an accurate history and physical exam so that we get the appropriate diagnosis for that patient. Sometimes assessment can be difficult with patients, especially if they're uncooperative or hostile. Make sure that you maintain a professional and calm and non-judgmental demeanor. Your goal should be to de-escalate verbally and facilitate communication and conversation. Refrain from using labels for patients or labeling patients based on their presentation. And a frequent caller may have a different complaint this time. You will all experience common users of the EMS system or frequent users of the EMS system during your time. Don't always assume that it's the same problem every time. Give the patient the opportunity to deliver information to you and to provide an accurate assessment. The one time that you may assume that nothing is wrong with the patient because you've seen the patient before may be the one time they truly need your help and assistance. As far as history taking, determine what the problem is or what may be causing the problem. Gather a thorough history and use questions that are open-ended. Let the patient tell their story. After all, this is their emergency, not yours. Give them the opportunity to share their story with you and use that information to help diagnose that patient. For unconscious patients, you can survey the scene for medication containers or medical devices, or you might be able to rely on bystanders or family members that are on the scene to help gain that history. Make sure you obtain a sample history, and you can use the OPQRST mnemonic. Refer back to some of the assessment lectures where we talked about sample being a good starting point. Use sample plus. The sample history should drive further questions and further conversation for the patient to help glean additional insight into their condition. Make sure you record any allergies and medical conditions and medications for your documentation and so that you can transfer that appropriate information to the receiving facility. Some patients can take numerous medications, and you may need to take the medications or a medication list with you to the hospital. If you do take the individual patient medications with you, make sure you document that thoroughly, including the name and location where the medication was stored during transport and who you gave that medication to when you got to the facility. The phases of the EMS call are important. And if you don't recall the phases of the EMS call, I would encourage you to go back to look at our assessment lectures again. But let's hit it briefly and make sure that we understand the key things that are going to occur in each of those phases. The dispatch phase is where you're getting information from the dispatcher relevant to your patient care. As noted earlier, understanding that dispatch can only convey the information they receive, and not all dispatch information is going to be completely accurate. When you arrive on scene, you'll enter the scene survey phase. You should take a windshield survey of your environment, and as you're approaching the patient, you should note the patient's condition in their environment, their body positioning, their demeanor. Are they engaging with you? Are they look at you when you walk in? Are they able to engage in conversation? Then you move on to your primary assessment phase, determining the patient's level of consciousness and making sure their airway, their breathing, and their circulation are all intact. Generally, if a patient can communicate with you without effort or excess noise in the ventilation, their airway is patent. For breathing and circulatory, you're going to have to touch your patient. Visualize chest wall expansion. Put your hand on the patient's arm and grab a radial pulse. Remember, a pulse requires you to feel it, requires it to be palpated. If you have immediate life threats in that primary assessment in airway and breathing and circulation, you should stop and treat those now. Based on the information you receive from your primary assessment, you'll move to make your transport decision. Is this patient so critical that we need to move to the ambulance and begin transportation immediately? Or do we have time to stay on scene and gather more information? Or perhaps is the patient so critical that we're going to be stuck on scene in the primary assessment phase trying to address those immediate life threats? Once transport decisions are made, you'll enter into the secondary assessment and history phase, and this is where you'll use the mnemonics like sample and OPQRST. During transportation, make sure you're constantly reassessing your patient. The general rule of thumb is 5 minutes for critical patients and 15 minutes for stable patients. But in reality, it should be a continual process. You should be continually engaging in conversations and assessment with your patient. And if you're delivering treatments, reassessing your patient to ensure that those interventions are making the appropriate changes. And then when you get to the hospital, make sure you give an appropriate handover. Make sure that you communicate the appropriate information to the receiving facility to ensure that the patient's continuum of care is indeed the most appropriate care they should be receiving.